Well, good evening, friends. It is Humpday Happy Hour with your good friends at the Dentist in the Know. I'm Dr. Chad Duplantis. I am a restorative dentist from Fort Worth, Texas, and I am not the usual starter of this show. I won't call him the host because I think we're all hosts, but I'm not the usual starter of this show. You're probably looking for Dr. Jeff Horowitz, but he is in Transylvania or something like that. He is solving the world's problems and ending world hunger. And he's on a cruise ship right now, kicking his feet up, looking out at the sea and enjoying actually beautiful part of the world. Actually, I'm sorry, my dogs are going nuts right now. I apologize for that. But Jeff is actually enjoying the sea over by Bulgaria. His brother-in-law is from there, so he's enjoying Bulgaria. But anyhow, tonight we're here to bring you your backstage pass to current trends, issues, politics, an inside look at education in the world of dentistry. I'm here with my good friend, Dr. Jennifer Bell, and our guest tonight is another good friend, Dr. Jose Chow. He'll be with us here shortly. But Jennifer, I hope I didn't butcher it too bad. Welcome.
Just lacks some of the enthusiasm that we would like to see.
Well, it was funny. I don't think either of us really knew that Jeff wasn't going to be here tonight. And like right before we went live, I'm like, I don't have Jeff's script.
He does have a great script.
Yeah. So I had to wing it. So I just tried to be as authentic and as real as possible. It was authentic. That's for sure.
You know what, Chad? We would all really appreciate if more media outlets just went authentic.
Authentic is the way to go. And that's all that I wanted to be, was authentic. So
that's all we
what's
can do.
going on in your world?
Not much. We just got back from a Labor Day trip to Disney World. So,
nice.
I'm detoxing off of all that fun.
Yeah, nice.
Yeah, it was good. It's always good to carve out a little time with the family, and my parents were there. My sister and brother-in-law and my niece were there. So it's really fun to do those things with a 4-year-old, and you forget that, my kids are growing up. And so it's nice to see it through a young one's eyes again, and all the excitement and magic that really is there. So it was good. What'd you do for Labor Day?
Well, before we get to what I did for Labor Day, do your kids like Disney World? Year 3?
Yeah, they have a good time. I think they're starting to phase a bit out of it. Maybe we'll come back. But I think they might whine going, but then they get there and have a great time. We've been there a lot. We're on the East Coast. We're not that far away. So we probably have also just done it maybe a bit much. So
my family is certainly not the Griswolds, where, remember when Clark was in all that trouble and he was like, why did I ask you what you wanted to do for family vacation? Where'd you want to go? He thought they were going to say Wally World, and they said Hawaii. I've always hoped that my kids would say that. No. My kids are 21 and 18, and my daughter was begging. You almost had 3 Duplantis in Disney with you this past weekend because she was begging to go for Labor Day weekend. But we did not. We hung out at home and really just kind of chilled. Labor Day is like always kind of like hit or miss with us. We didn't, it was kind of like dreary, and it was like it was about to start raining, and then it started raining late Labor Day and then rain for the next few days. But it was really just kind of a quiet weekend. Nothing exciting.
That's good, because it looks like fall's going to be super busy and going right into the first of the year. So maybe just a little downtime never hurt anybody too much, right?
How's work?
It's really busy, but overwhelming most days. We're continuing to work through staffing challenges and trying to find the right fit for our practice. And it's just interesting. You saw the post today. It's actually a colleague of mine who practices here in Raleigh. We went to dental school together, and her post about how do we manage hygiene, income, and demands for salary. And you can see both posts, right? You and I are on enough other groups where you see hygienists post questions about wanting to demand higher salaries, wanting to push those boundaries, either for elongating their appointments or increasing their pay. And then you've got the flip side of doctors trying to manage the business compression that is really happening. from a supply side. Everything is more expensive. And so you're just adding salary costs to that as well. So it's interesting to see how this is all kind of compressing. And I think one post comment sort of mentioned that. He's like, here are
Jim
two,
Richard. Yeah,
yeah,
that was fantastic. That was the
contralateral
comment of the day. Yeah,
posts going on
yeah.
simultaneously, which means at some point something has to give. And I will tell you, so far, the thing that has been giving is statistically the first time we've seen decrease in dentist salary. So obviously, as profit goes, so do most dentist salaries. So I do think dentists are giving up a little bit of their income, which had already been kind of fairly leveled off. But then I think you're also starting to see dentists going back to doing scaling and doing more hygiene visits to compensate for either the fact that they can't find somebody to come work in their office or they just can't afford it. If you're in network, it's just really hard to squeeze
It is
out
hard.
$60 an hour plus benefit.
It is hard. Yeah.
So I thought that was a great post. I think it's always interesting to keep those questions going because number one, if nothing else, it makes doctors feel like they're not alone, that everybody's sort of dealing with some of the same problems and in some of the same trenches, trying to figure out how to make ends meet. And, unfortunately, to date, no one's come up with the master plan on how to solve the current problem.
I would totally agree. I would totally agree.
Why don't you tell me what you're doing this weekend?
I will. But hold on. I got to tell you something. We were talking about practice, so I don't want to steer clear of that just yet. I have some exciting news.
Yeah.
Dr. Kirkham and I, we have our first associate working with us that started 3 weeks ago. She's only there on Mondays. And, after the first Monday she was there, I was like, my God, I will do whatever it takes. You need to be here more. It's been truly amazing. I mean, our schedule this summer has been absolutely nuts. We've started off September. August wasn't great compared to the rest of the months, but it was good. It's nothing that I'm going to complain about, but September is definitely here. But I'll tell you what, on Mondays, it was me by myself with 3 hygienists, and that's brutal. It's a beatdown.
It is brutal.
Monday's the worst day of the week. I mean,
Yep.
You've got every freaking patient that had something happen over the weekend.
Yeah, especially a long weekend.
Needs to come in. And so we were trying to carve out some time for emergencies and trying to do all this and do all that. And then we had Dr. Walsh start a couple weeks ago on Mondays, and it's just been a blessing. So it's been a lot of fun. It's uncharted territory for me. So I know a lot of people have had associates in the past. We have not, at least in the 20 plus years that I've been there. So it's really exciting. And I think we found a great doctor to fill that void for us. So it's wonderful. However, you had asked me what I'm doing this weekend. So this weekend, I am going to Nashville, which, not that I don't go to Nashville often enough. However, I am going to see my son. But I am going for the International College of Dentists. So it's kind of exciting. I'm going to be with my good friend, Dr. Partha Mukherjee. And we're going to have some education on Friday and some fellowship on Saturday. And it should just be a really good time. And I mean, here's the deal. It's like you throw a conference out there, and if it's in Nashville, even though I do have another reason to go there because my son lives there, I'm going to go. Nashville's just a great place. So
Yep.
I'm really excited, and it seems to be a really great group of dentists. So thank you for getting me involved in
Congratulations on your acceptance and welcome to the family. We're always happy to have more members.
I am excited to be there. So it'll be a lot of fun. And it's funny. It's one of those organizations that I really don't know anybody except the person who I've been speaking with on the phone. And of course I know Partha. And so Partha's, for those of you that don't know Partha is like the freaking nicest guy in the world. He is just, he's a good human, and he gives so much of his life to organized dentistry, and it's really a breath of fresh air to see him. So if you don't know him, look up Dr. Partha Mukherjee. I don't know how to say his last name. I apologize. I'd say Mukherjee. But anyways, Partha is truly one of the best people on the face of the earth. So I'm glad that I'm going to get to see him. His only problem is he's an Aggie. Um, but then again, so is our guest wife tonight. So by default, Jose's an Aggie in law, I guess. So anyhow, that's enough about that.
Well, we're excited to have you in the family. It's a great organization, and its pillars are really important for those who are making a difference in our profession through education, teaching, philanthropy, giving back their time, energy, and resources and their gifts to others. And so, you and I can speak for both of us, like, you'll be so humbled by the things that people are doing out there with their gifts to others. And, I definitely feel like I don't measure up most days for the things that folks are doing and giving back. So it's always really nice to be reminded of the blessings that we have, that we've developed and learned over time, and then how people are leveraging that to make some type of difference on this earth before they go. And there's been some really great people that are members, so really cool.
That's awesome. Well, I'm excited. I'm excited, and I'd imagine that you probably have some news for us tonight. Do
Of
you have some
course,
news?
always.
All right. Well, I'm going to turn it over to you, but I'm going to come on at the end. So you just kind of give me when you're ready.
You got it.
All right.
All right, team. We're always here to bring you the latest. And this one's a tough one for me to swallow because we've been talking a lot about legislating from within federal organizations and entities. So, Health and Human Services, NIH, CDC, coming up with all these additional rules and things that might be outside of their scope. And we've recently seen that in Texas, with the FTC coming out with these non-compete changes, and now the federal court system is saying, wait, that's not within your charge. You don't actually have scope to overturn those things. So we're starting to see some change now that some of the Supreme Court decisions have been made. So I don't know if that's why the fury of these organizations is sort of picked up to try to get more of these things out quickly, because as more of these cases get settled, it will become more difficult for HHS, NIH, CDC, et cetera, to come out with new regulatory language. But so they're working pretty hard on your behalf. And the latest one coming out of the Health and Human Services, we'd heard about this back in May. It was a pretty dense new federal rule on non-discrimination in healthcare. This applies to the LGBTQ community. It applies to those with limited English proficiency, those with disabilities, and other niche areas within that. The comprehensiveness of this ruling now provides a lot of guidance to medical providers and what they now have to do on behalf of those patients who show up at their office. For instance, you are required to provide interpretation for your forms and for your exams, et cetera, at your own expense for those patients who are deaf or speak a different language from your own native language. If you're not comfortable speaking in a foreign language, or you don't have support staff that can interpret for you, or the patient doesn't bring an interpreter with them, you must be able to provide support for that at your own expense. It's just one of those little things. If you have equipment such as your dental chair that can't be accessed by certain folks with disabilities, it will be your requirement to modify your operatories, modify your chairs, et cetera, to make sure that they are accessible. If you have telehealth and you're offering that benefit, you also have to have interpretive capability there as well, meaning you have to offer your services in a variety of languages, et cetera. So it's really pretty far reaching, I think, what this could look like. I don't have a lot of clarity yet on whether or not this will be most enforced on individuals who are enrolled in Medicare, Medicaid, and state plans. If you are providers for those particular federal agencies or federal insurance providers, then for sure these rules are going to apply to you and you will have to comply. How far that will reach out into the private sector if you are not participating in Medicaid and Medicare is not clear yet. But as we've seen with many other regulatory languages that come out, being in network for Medicare and Medicaid does not impact whether or not those rules apply to you. So it's important for you to know because you may have patients that start appointing to your office that will demand these types of services and support. And I don't think any dentist wants to deny care to anybody and not be able to help. It's just generally not in our nature and not why we pursued the profession. I think the concern always is to what expense and to what level do you have to be able to provide support for, any nuance that might walk in. And we know that those can be pretty vast and varied. So I'm going to continue to watch this particular language because I don't quite have a good comprehensive understanding of what that will look like on the ground for those of us in private practice and what we need to be prepared for. So we'll try to give you updated information as that comes forward. One other piece of information, we do try to update you on some of the things that are happening on a state-by-state basis because we know that those directly impact many of our viewers. For those dentists that are in Pennsylvania, legislation did just pass that you do not have to take virtual credit cards, even though many insurance companies are trying to force providers to use virtual credit cards as a form of payment. And we know the issue with providers having to take that virtual credit card is they then have to take an additional 3% or pay these fees to be able to process the payment. That's on top of their already discounted rate. So it's one thing after another. And if the patient paid their portion with a credit card too, that's another 3%. So all of these little percentages start to add up. So Pennsylvania is looking out for their dentists and for their medical providers and did pass legislation to say that you do have an option to opt out of virtual credit card programs. Illinois also passed additional legislation recently, opening up some additional coverage in the medical space for patients that show up with significant jaw injuries by accident or disease. So cancers, traumatic brain injuries, car accidents, et cetera, to open up medical benefit for those patients who might need dental alveolar surgeries, implants, extractions, full mouth reconstructions, et cetera, to open up that benefit for them and pull it out of the dental benefit. So, we'll continue to see how these things shape out. But just so you know, that is now Pennsylvania, Illinois, Arizona, Florida, Indiana, Iowa, Louisiana, Maryland, Missouri, Ohio, Rhode Island, Tennessee, and Virginia, all recently passing dental specific benefit legislation. So it's a hot topic. We know that quite a few states are going to have medical loss ratios and dental loss ratios on their ballot for the fall. So we'll get that full rundown and full list for our listeners as well, so they can stay engaged and know, is this the right way we want to vote for this or not? And the ADA has their house coming up soon, and we always hear of a few new things coming out of that as well, and their stance and strategic plans moving forward for 2025. And with that, that's the news.
I just wanted to start singing that song, I'm an everywhere man.
Or did you ever have to learn the state song? My kids know it. I never had to learn it, but
I didn't either. My kids knew it too. But then again,
that must have been a different generation.
This may sound really stupid, and pardon my ignorance. Did you ever have to learn? Do you all have a North Carolina Pledge of Allegiance?
No, that's because you all can be independent at any time.
We have a Texas pledge. And the funny thing is like you'll go to like certain events, like a ball game or whatever, and they're like, would everybody stand up and please join me in the Pledge of Allegiance? And then we're going to follow it with the Texas pledge. And all the parents are sitting there and they're like, and
they
don't actually kids are like boom, 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 boom. And I'm like, what the hell is this? I never learned this. And I had to take Texas history in 7th grade. I didn't even know there was such a thing.
Is that a new thing, or like has it always existed? You just didn't have to recite it?
I'm not sure.
Huh.
If it existed, I did not learn it. We'll ask Jose if he learned it. But anyhow, hey, there's one bit of news. You did a great job with the news as always, but I think there's something that I want to touch upon. It's a little bit of dental news, and I'll bring Jose up. I don't know if Jose knows anything about this, but there is a story that's been going around, and I'm going to post a link because the one of the heads of Freedom Founders actually kind of posted a rebuttal or an explanation, as you, if you will. It's about 43 minutes long, so I didn't get to watch the whole thing. However, maybe a month or so ago, we talked about a guy who was in dealing with some investments for dentists. His name was Mark Jackson, and all of a sudden he went missing. Well, the story deepens and deepens and deepens, and apparently it was a real estate investment deal. I'm not going to say it was. I don't know enough about it to comment, fully on it. However, this gentleman has escaped the law to the tune of $26 million from investors, many of which are dentists, and is evading not only the law enforcement officials, the FBI, but also the police. So a really interesting story. If anybody happened to have invested with them or happened to hear about it, I will post the link to Dr. Phelps's rebuttal on this. And I just want to reiterate, it is not Dr. Christopher Phelps, it is Dr. David Phelps, who was a member of this group. Both of those are both well-known dentists. But really interesting rebuttal on dentists and dentistry. Dental Investment Group is where they've kind of been hitting after it.
Is that group still in existence, Chad? Is that group still operating?
Freedom Founders?
Mm-hmm.
I believe that they are, but don't quote me on that. I don't know to what extent. It's all, to me, it's all very confusing, but I'm still trying to wrap my head around it. I just know $26 million. Guy's missing. A lot of dentist money is tied up in it. And I mean, we're not dentists with like 5, 10. I've heard $120,000 was the minimum investment. That may be, inflated, but that's the number that's been kind of floated around. Once again, I don't want to speculate. However, it has been a very, very interesting story to follow, and please come to your own conclusion. But the moral of the story is just always use a trusted advisor. We had Todd Dubrow on a couple weeks ago. He's a very trusted advisor. Use a trusted advisor. Get resources outside of your own ego to help you invest wisely, because this is a nightmare for a lot of people involved. And somebody might be living fat and happy in Monaco for all we know. I have no idea, but it's not a good situation. So I hope I didn't butcher that too much, but it's very interesting.
I think it was important because it came across our feed, and I can't remember if they posted in our group or not, but they thought he was missing for a long time, and there was a lot of so sorry for this guy. So anyhow, fast forward, let's talk about our guest tonight. So I want to introduce our guest. This is an honor for me because it's a really good friend of mine. It's a person that I work with on a regular basis, both on the turf at the golf course and in the office, most importantly. But Dr. Jose Chow is a 2004 graduate of University of Texas Health Science Center at San Antonio. He was about 5 years after me. After that, he went on and did an orthodontic residency at the University of Nevada, Las Vegas. He's born and raised in El Paso. I'm not even having to read any of this, Jose. I think we've learned enough about each other over the past few years. But
you just know about memory, man.
Yeah. But I do know that one of the things that really always stood out with me with Jose was whenever we're in study club, he's always like very analytical. He doesn't answer right away. He thinks about it before he comes up with an answer. And maybe that's because he went to Stanford, and we know that very few people actually get into Stanford. But Jose went to Stanford, majored in biomedical or biology. It was some sort of human biology.
You're almost there. There you go.
Human biology, Bachelor of Arts in Human Biology. I did read it. I just thought I could give a lot of it verbatim. But
he's slow.
But yeah. So anyhow, Jose and I practice very close to one another. We've known each other for a number of years. We have a lot of mutual friends, and we've started working together recently. But there's a lot of things that Jose does differently than most orthodontists, and I think it's very interesting to watch. And so we want to talk about a number of those things tonight. Um, Jose and I always have these conversations because I feel that orthodontics of past has really lacked in kind of one of our main talking points in dentistry today is sleep. So Jose and I have talked about taking some sleep dentistry courses and seeing how we can help some of these patients out down the road. But Jose also works a lot with myofunctional therapists, and we want to talk about that. So Jose, welcome, man. It's good to have
Thanks,
you.
man. Thank you. Great to be here. I appreciate the invite.
Yeah, well, it's an honor to have you. And one of the things I didn't mention is Jose's wife is also a dentist. She went to the University of Texas Health Science Center at San Antonio, and they're
way better dentist than I ever was, man.
Yeah.
No doubt. We all know who the real brains of the Chow operation.
Well, I will give Laura credit, and Laura, I'm sorry that I did, bastardize your Aggies a little bit earlier, but it is what it is, So let's JB, where would you want to start if we had an orthodontist on the show?
Well, I would really love to know your journey from being an orthodontist and then that spark or movement towards myotherapy, your interest or intrigue in sleep, because it still seems to be a super sticky wicket. Like, many of the orthodontists I work with here in the community, we just cannot seem to get on the same page. Like GPs are studying and doing one thing, orthos studying and doing another. And so we have these really complex cases that come into the office. And, I find myself pushing in one direction. I find them pulling and pushing in a different direction and trying to come up with a cohesive treatment plan. And then also magically reading into the future to figure out, okay, but what's the patient look like at 40, 50, 60 when they're back in my office? And I'm trying to figure out how to undo what we've done or now make it better. So I'd love to know, just from a life cycle, if you will, you finish an ortho, you move into this, and you're doing traditional ortho. At some point, there must have been a tipping point for you on wanting to look more at myofunctional therapies and sleep.
Absolutely. It was probably almost by accident. And I think any orthodontist that's practiced long enough will tell you you're going to learn a lot through your own mistakes. If you're lucky, you pay attention to others' mistakes, not to dig at anyone, but you tend to see relapse. It's almost, it's probably the bane of every orthodontist existence, but it's a reality. And a lot of times it almost fell in my lap by, we'll say, misfortune initially, where I was starting to see certain relapse in the vertical plane, and I couldn't really put my finger on it. I went back through records and I couldn't, and I was probably, I'd say, still relatively young in my career, maybe 4 years out, something like that. And, you read a little bit about it in residency, and, the majority of the time, tongue rakes, and, you make a retainer that's got a tongue rake built into it. And that's how you maintain the tongue back, which, tried and tested. Sure. Yeah. That can work in many cases. In others, it doesn't. And those were the ones that really kind of started to grab my attention. Like, first off, why didn't I catch it? And I went back and looked over photos and records, and I just wasn't really looking close enough. And really the other element that I think is tricky, to kind of go back a little bit, and I hope I don't go off on too many tangents. If I do, just stop me. I think airway, sleep, myofunctional therapy, it's like a lot of other things in dentistry, and definitely in orthodontics, where there's waves, right? For the longest time, everything was extractions. You know, if your mandibular incisors are tipped anywhere beyond 90 degrees to the mandibular plane, you extract. Well, those are extremes, not to throw too many names out, but you know, the Tweed Foundation got a lot of slack for that. And then you actually talk to some Tweed guys and you see what they're really doing. And no, it's not that extreme. And then came the non-extraction, no matter what, camp or philosophy. And, you know, you started to get just these profiles and these, you know, just incisor angulations that just look terrible on the other end of the spectrum. So a patient asked me a long time ago, probably again, 5-6 years out, and they came in with their notebook to the consult, which automatically was a red flag for me. And the first question they asked me was, do you practice, and they looked down at the notebook, dentofacial or orthodontics, and do you practice dentofacial orthopedics? I'm like, oh, okay. And being the smart aleck that I am, I kind of moved out of the way and I pointed her to the diploma on the wall because it says certificate in orthodontics and dentofacial orthopedics. Truth be told, I didn't really know what dentofacial orthopedics really meant. I thought it was just fancy talk. And then her next question was, are you an extraction or non-extraction orthodontist? I said, well, if extractions are needed, I'm an extraction orthodontist. If extractions are not needed or necessary, in my opinion, I'm a non-extraction orthodontist. And if I'm on the fence, I start non-extraction and then we see where it goes from there, which I think is kind of where how we should be looking at it. And I think to your point, Jennifer, a lot of times there's almost like a tribal element to it where certain camps are saying everything is sleep, everything is apnea. Other camps are like, no, that's ridiculous. And myofunctional therapy doesn't work. And it's all, just quacks and this and that. And like everything else in our profession, probably every profession, yes, there are some outliers that are just crazy that, you come in with a bombed out second molar and, well, we should get a sleep study first. Like, what are you talking about? It's not all, sleep, but to redirect, I honest to God can't tell you where I really met the first myofunctional therapist. But I do remember that this young man came in, it was a case that I had finished. It was one that I had taken on when I joined the practice as an associate, finished the case. Everything was great. Kid comes back 3 years later, 3 millimeter anterior open bite. Everything else is socked in class 1. And I'm looking at it like, what the heck is going on? And, I see the tongue thrust, and I want to say that there was one myofunctional therapist that was local. And after I went back and looked at all the photos and everything, I thought I must have missed something, because I said, all right, we'll swallow real quick. And of course, couldn't miss it. And he went back, did a quick evaluation. I got the report back from the myofunctional therapist. She said, no, it's definitely a habit. He's very motivated to improve it. Went through a few sessions, came back to me, we retreated. And I took photos when he came in with relapse, and I took photos when we restarted him. And if he was 2 to 3 millimeters open, pre-treatment, pre-myofunctional therapy, he was about 1 post without me touching anything. So that's kind of when I knew, okay, there's got to be something to this, the balance between lips and tongue. So that definitely got my attention, because that was one of those cases where I just could not pinpoint it. And I asked the therapist later, I said, is there something I missed in these photos? And she said, well, it depends when you saw it. If you saw this kid, if he had phase 1 early, and everything was being held with functional appliances or with fixed appliances, it goes into, observation for 6 to 12 months, maybe starts back again, you're never going to see it. It's going to happen over time, because there's also different degrees, different levels of, tongue thrust and parafunctional habits and whatnot. So that was probably the first time where I thought, okay, first of all, that was pretty cool that I didn't have to do anything aside from, retreat, re-level, close the bite. But as far as addressing the habit, I didn't have to throw a bunch of appliances in there and just kind of cross my fingers, hope they worked. The later challenge was that myofunctional therapists, or at least at that time, few and far between. There were not very many. She was the only lady that was around here. And then she retired. She was maybe, gosh, I don't want to butcher this, but I haven't said her name, so I can say it. She was late 60s. And then I believe she had a stroke and then retired. And that was it. I think the closest one we had at that time, or that I knew of, was in Denton. So that was really tough. And I started to see more and more patients with, maxillary deficiency, very narrow maxillas, and a lot of them, they came with the same thing. They usually come in pairs. Anterior tongue thrust. Some of them had tongue ties, as we call them, or very high lingual freedoms. Some didn't. And that's kind of been a new element for me. And I do think it's an evolving field. To your point earlier as well, Jennifer, there's still a lot to learn. There's a lot of good research out there, and it's going to take time. I don't think it's a process, especially on really complex cases, some of which are surgical. And I learned that lesson the hard way. I won't tell you how, but maybe after a little more Eagle Rare, I will.
Right. Well, we had Convisor on, and did I say that correct, Chad?
Commissar, yeah.
Convisor. And he's a big laser guy, and he really honed in on lack of breastfeeding and he goes back to the very beginning, and that palatal formation, tongue movement, freedom of tongue movement, all of that from the very first few days of life all the way through their first year predicts a lot of what you'll see in future years. And if you don't develop the palate, you don't develop proper tongue movement, or you don't free it up if it needs to be free, will likely predict, I guess is what he's saying, the data is starting to show, which of those cases that you will then see at 12 that will destabilize very quickly, because you can't just fix it orthodontically. There's a lot of other musculoskeletal issues going on. And then you add the layer of sleep in there. And where do you look for that? When do you diagnose it? When do you add that to the particular formulary to say, in the patient that you fixed, it was just a tongue issue, right? But who knows? And for dentists, okay, but how do I know? How do I look at a patient and say, this is just musculoskeletal issue alone, and if we solve that habit, we can fix the patient, versus, oh, shoot, it's also a sleep apnea issue. So we've now got multiple disciplines trying to solve the same problems and put the patient on the right path. And I think most GPs in particular, and I think ortho's starting to feel the same way, is just very overwhelming, because my observation, we're the only one looking cohesively, looking at that whole big picture and trying to figure out root cause to solve the problem, where medicine has become so fragmented that ENT is just looking at the tonsils. If the tonsils don't need to be taken out, they sort of check that box and they move on. And you're like, yeah, but how about the fact that they're not hitting their growth marks? They're not moving their tongue correctly. They're not there's all these other things, and they're just, it's sort of off the docket for them to discuss. So a lot has sort of fallen on the dental field's lap, I think, in seeing those patients. And I can't tell you how many I've referred back to their pediatrician or ENT saying, something's not right. It's out of my scope to diagnose, but I can put enough of the pieces of the puzzle together. And the parents know. You've seen that face, right? When they say, you're the first one to finally validate all the things that I've been thinking, and no one believes me. They think I'm crazy, whatever. And you can just see this huge weight come off of them to say, I don't think you're crazy. In fact, I think there really is something here going on. It's out of my scope to diagnose at this point, but I think you got to keep pushing.
Well, Jose and I have a case. And there's another thing that we're competing against too. And I think one of the biggest things that we're always competing against is insurance and cost. It's either insurance and cost, or it's insurance or it's cost. It's one of those three,
Mhm.
whether they're combined or separated. And so we had a case several years ago that just resurfaced very recently. And young lady came to me and had this anterior open bite. And it was basically right after orthodontic therapy. And so, of course, with cost, we're going to go back to the original orthodontist. We go back to the original orthodontist, and the original orthodontist gets it. That's the sad part. They get it. And they're like, they get part of it. I think this is a sleep issue. And so we're going to prescribe you a powder that you put in your drink before you go to sleep, and you're going to sleep better. And this issue is going to go away. And then we'll treat it. And I'm like, wait a second. This doesn't sound right. and it's
You know what
like,
that powder is? Because that sounds amazing right about
yeah. Trust me, dude. I still use it to this day.
now. Here's my
Raw
powder, bud.
nutrition.
I was gonna say, is that
Yeah.
melatonin in
Yeah.
a capsule form?
So anyhow, we're like, all right, we get it. That's part of it. That's a piece of the puzzle, but we're putting a band-aid over the problem that's probably not going to fix
Yeah.
the underlying problem.
Exactly.
So then you're like, okay, let's go to Jose. So they go to Jose. Where do they go? Myofunctional therapists.
Mm-hmm.
And then this is where it's a whole convoluted mess, because it's like, well, we're going to go to this myofunctional therapist, but we're not going to go to the one that Jose recommended. We're going to go to this one that our insurance may help pay for. So we're going to go here. And then this myofunctional therapist says you're tongue tied, so you're going to go here. And then Jose and I are completely boxed out of the equation. And then when they get there, they go to another orthodontist, because that's where the tongue tie people who decided not to clip the tongue tie send them to that orthodontist. And they go to that orthodontist. And then the patient resurfaces back at my office with the same issue, because the solutions that were suggested finally were dismissed because of cost, insurance, or a combination of the two.
Yeah.
And, it's kind of this vicious cycle. So I think one of the things that really comes in, and it comes from, not from you, Jose. Yes, of course it comes from you eventually, but it comes from Jennifer and I mainly, when we start quarterbacking this whole situation, is like, we've got to tell people, I'm sending you here because of loyalty, because of trust, because of their skill level. And this is why I'm sending you here. I think there becomes this huge, this is why I'm sending you here. And then if they need to send you elsewhere, you've got to trust their decision and listen to the education that they provide you as to why you need to go where you need to go. And it's unfortunately a vicious cycle that we go through, but I think there so much lies in patient education and the why behind what we do.
Mm-hmm.
Yeah. And it's a interesting point that you made earlier about that face that they make where, okay, somebody's finally getting
Listening.
it. And then you have the kind of a similar face, but it spins off to say, well, you're the fifth orthodontist I've seen and nobody has said that.
Mm-hmm.
Why haven't they said that? This sounds suspicious to me. And I'm not quite there yet to tell some parents what I'm really thinking in my very smart aleck nature, to say, okay, well, let me get this straight. You've been in speech therapy since second grade. You're 15 and you still can't make certain sounds, and nobody's told you anything. And all of a sudden somebody's telling you how your tongue is still restricted or is restricted, which is leading to X, Y, Z, all these other things for which you came here, because you didn't come here because of the speech stuff, but it came up in conversation. So now we're kind of showing you, oh yeah, it's all tied together. It's kind of making sense. But I don't know about this stuff because nobody else mentioned it. Everybody else that we've seen along the way, nobody's seen it. Surely they would have seen it. So I'm like, okay, but nothing's changed. What does that tell you? There must be something else. And not to say everybody else has been wrong necessarily, that's, again, this is stuff that's new and up and coming. Heck, I'm learning new stuff about it. And there was an unfortunate case where I get the report back from a myofunctional therapist that was working remotely, because some of the stuff, like I said, few and far between. It's tough to get into some of these places, the few that we have here locally. But luckily, some will do consults virtually, and it can be very effective. But much like anything else, at least in orthodontics, the frustrating part is we're somewhat used to it, I guess, that, I don't know, I'll throw a random number out there. Don't crucify me if it's not exactly accurate. I'd say 85% of, especially complex cases, orthodontic cases, there is probably an element to that case that is 85% patient dependent. If they don't do what we ask them to do, how we ask them to do it, it's not going to work. And myofunctional therapy, unfortunately, especially if there's resistance from the get-go because they've never heard of this. When we were young, you just got braces and that was it. Or if your teeth were really crooked, they just took teeth out and you were fine. Well, okay. All my friends have this type of retainer and it's always worked. All right, well, how many friends do you know that had braces? Well, I've got 20. Oh, okay. I got 200 cases back here that will prove otherwise. But you don't see those because you don't do this every day. But there's already kind of a resistance to it. And then they see cost, to your exact point, Chad. Insurance doesn't cover it. It's $100 a session. And unfortunately, if the kid sees it as beneficial and they start to see maybe improvement, they start to sleep a little better, or they just hear their speech changing a little bit. Okay, now they buy into it. But the ones that are resistant from the jump, again, it's the vicious circle. They don't do what they're told to do. And then, it's just a big sham. And we're definitely not going to do that. Even the insurance company proves it because they don't cover it. That's a totally different topic that, or a different road that we don't necessarily need to go down. But that's kind of where some of that challenge lies too. But in that particular case, there were things I hadn't seen in a few different parts of the tongue that the therapist caught and said, oh yeah, he's been in speech therapy for this long, but he's got a posterior, I forget what the exact word was, but it was a certain type of tongue tie or tongue restriction that even I don't even know how to search for that, but it made sense. And she said, yeah, the posterior part of his tongue is completely weak. It has zero strength. There is no way this kid's ever going to be able to truly posture correctly if he doesn't follow these exercises. And yeah, we do potentially need a very specific type of tongue release, or it's just not going to happen. And the cases that, like that case you were mentioning, Chad, and others that I've seen, the ones that are really, really, really difficult, and I've had to have this conversation with even some adults, is that when you have maxillary deficiency in the AP plane, and it's a true retrognathic maxilla, most of the time, or almost all the time, especially if it's a class 3 tendency, that's when you get into some really muddy waters, because you got a kid that's growing in a class 3 relationship, mid-face deficient, more than likely transverse plane, AP plane, you expand, but they're still deficient. The maxilla is a fixed jaw. You can't posture forward. They put them in a snoring device or some sort of other anterior posturing device. You're making that class 3 way worse. What do? Well, it's it's not simple, but some of those are almost pretty clear to diagnose. Yeah, you're an orthodontic case. You're an impaction advancement. And then depending on what your occlusion looks like, you may be extractions with an anterior rotation of the mandible, but those are really tricky, because now we're talking myofunctional, possible tongue release, and orthodontics.
So let's talk about those cases, because I find those to be the most challenging, not just for ortho, but for GPs too, because we see those cases that weren't treated orthognatically or myofunctionally and just masked, basically. You know what I'm talking about. They retrocline those incisors as much as they can get by with. But then they grow, or they have a late mandibular shift, or as we all know, all individuals sort of elongate and rotate forward over time. So eventually this busts through, right? Or they start developing significant TMJ issues. And so at 30, 40, 50 years old, we see them as GPs going, okay, how are we going to solve this particular problem? Because they're having significant TMJ discomfort, or they're chipping and breaking their upper anterior teeth, and they want you, they're the ones that Chad and I, like, you have your cases that you just want to poke your eye out with. It's that chip number 8 that you repair 4,000 times before you finally convince them that it's a functional issue and not, that you
and they don't
have
get it.
bonding systems or whatever.
Oh yeah.
And so let's take those cases back to when you treat them at 12. And I haven't figured out a way, one, to communicate my dislike of these cases and like, how do we move forward? And then when we compromise these treatment plans, like how well informed and how much are we telling the patients and the parents, look, this is because at the end of the day, it's an aesthetic treatment plan. We're going to put them to where you want them, and they're going to look great in your senior photo. And by 30, they're going to look like shit. And you're going to hurt, or whatever it's going to be.
Oh man, I didn't know we could cuss on the show.
Yeah, we drink wine.
Man.
Bourbon.
Okay.
Now, so at what point do you say this is an aesthetic treatment only, and I'm in? But I'm just telling you, when this destabilizes, and it will, especially when we do it to boys, because we know we treat them at 14 and then they keep growing to 22. And maybe I'm just airing my grievances, but that's just the things that we see as GPs, because we do have long-term relationships with patients. So then you watch these things destabilize over time. Or like I had a case, we're all sharing cases. I had a case recently for a young female, that exact case that you're describing, but she's also missing upper, to complicate things, undersized maxillary incisors, missing maxillary laterals. And was a masked class 3, and immediately finished ortho and TMJ discomfort. And so I went in and put overlays on all the maxillary teeth and opened a vertical up, and all of a sudden she's like, I feel great. I don't have any pain or discomfort. I'm like, conceptually I understand. So, as GPs, these are the things that we're trying to understand and figure out. And then how do we manage that with our orthodontic relationships and having those discussions? And, and as you just said, like, where's the line? Where do you draw the line to finally be the sarcastic son of a bee that you want to be and say, it's cool that you want to do that. I'm just not the guy for you. I'm not the girl for you. Like, I can't participate in this disaster any longer. So I will say, for fixed hybrids, I've gotten to that point where these are really complicated treatment plans and very expensive. And I will only do it with a particular surgeon or two that I have dialed that workflow in. And you're welcome to go get that done by anybody else. It's just not going to be with me. And that's okay. Like, we can all still be friends. I just like to sleep at night, and I'm not doing this. So
great point, though. And I know this isn't the point you're getting to, but I love what you just said, because I think it's important for the three of us, because we're all at that stage in our career. You two are younger than me, but you two are about the same age. But
inside, I'm way older than you, bud. You've seen me on the golf course.
Yeah, whatever, bitch. So anyhow, we have that. We can choose who we work with, and I'm at the point where I really don't care if you want to go to Joe's Smile Shop down the street because they have a $50 coupon. Go there. Just don't come back here, because that's not where I sent you. And I think we're at that point in our career where we're beyond like, hey, I'm not gonna promote this. You're gonna go to the places that I suggest, and it's not just one person for every specialty, but I think it's really important. So I loved what you just said, JB. Sorry, I had to interrupt, and I hope Jose didn't lose his train of thought. But
Jose's like, I don't want to touch this with a 10-foot.
No. I'll tell you a funny story that I kind of, It was a
nobody watches live. We can edit it out if you change your mind.
This one's great. This one I still It's one of those that I looked at. I think it was my TC that came to ask me this, and I wanted to just look at her. It's like, you're shitting me, right? Like, she did not really ask that. This is too easy. This is way too easy for me to be a smart ass. So I treated. I think there was 2 or 3 siblings, right? Treated one of them, and everything turned out really nice. Second sibling comes for a consult, and everything appeared to be fine. Well, mom goes somewhere else, just price difference. I mean, this other place was $1,500 less, and I was quoting an insurance fee. So you can imagine this was below Medicaid pricing. What the hell? Okay. And then comes back to me after that kid's done for my recommendation for thirds. I'm like, well, okay. Well, this is who I would use. Actually, that's not how it was. The sister I treated, I'm like, okay, you got to get these thirds looked at. Gave her the referral. She decides to go to the oral surgeon that this other place that she took the brother to sends to. Calls on a Friday. I'm out of the office. And she said, hey, we're at this other oral surgeon. I just wanted to see what Dr. Chow thinks about this guy, because they say they don't sedate for third molars, but this is where the orthodontist I took my son to sent us. So why are you asking me? First of all,
Yeah.
my opinion is go to the guy I sent you to in the first place, because it's for a reason. Number 2, she gave me she left the name with the front office. I looked it up. It's not even an oral surgeon. I don't even know who it is. Yeah, I mean, it's not even, I couldn't find it anywhere as even like a traveling service or something like that. But I'm like, an oral surgeon that does not sedate for full bony impactions. I mean, that should be your first red flag. Yeah. And mom had the red flag, but then she's like, I mean, he's got to be, this is the statement that I love. He's got to be good though, right? I mean, if the other guy sent me there, are you really, I don't know, probably not. But, well, I just wanted to get Dr. Chow's opinion, but can he call me back now because we're in the waiting room? Like, sure, my opinion's guy I sent you to in the first place. It's for a reason. That part to me, I just don't. That's, again, not to go off on too big of a tangent, but that becomes another challenge where everybody's mesmerized. You know, you kind of think, okay, I communicated with them. They're seeing what I'm saying. It's all making sense. And then the moment insurance doesn't cover it, or there's somebody else that's a little bit cheaper that says, no, you come, we'll put you in this appliance for 3 years and then you'll never need anything else ever. And that's all hogwash. And then they just go over there and do that. I'm like, all right, well, and then they come back, of course, after it doesn't work. And hey, what do we do now? Like, I don't know, but it's not going to be here.
I've gotten to the point now where you were saying, I don't know what to say yet, or I haven't become smart ass enough. I don't know. To say what you're really thinking when patients say, well, how come you're the first person that's ever mentioned that? And I will sit patients up and say, we are not all trained the same. We don't all invest in our education the same. And I spend my weekends and my summer vacations and time away from my kids to be better for you. We're not a commodity. We're not Walmart. We're not Target. I say it in a very loving voice. But at the end of the day, like, I've hit the point in my career where I'm tired of being put in a bucket with everybody else that isn't doing the same stuff that I'm doing.
Right.
So the only thing, and I'm even an in-network doctor, like, I'm doing all the things for you to make it easier for you to come here. And I'm providing you a COIS level education, which is like basically a second dental degree on top of the first dental degree that I paid for. And all the other, amounts of education that I've invested in to sit here and have a different conversation with you than what the person down the street can do. And I don't know how to help you discern what you want to believe and what you don't want to believe, but I'm not going to change how I practice and the philosophy of what we do. And it's either the right fit for you or not. Like, we're just tangent. We should just call this the tangent episode, because I am becoming very frustrated with the idea that I have to be the doctor for every patient. And I'm sure you feel the same way. Like, at some point, This is my philosophy. This is how I treat. And if you like it and it's what you want to hear and it's what you want to invest in, I'm all for it. And I'm going to be here for you. I'm going to come in on the weekends. I'm going to do all the obnoxious stuff that I have to do. But if it's not what you want to hear and you don't like it, that doesn't mean I have to be the doctor for you.
Yeah.
But there are plenty of other, I mean, we both live in communities where you fall out. The joke where I live, Jose, is if you fell out of an airplane, you would land on an orthodontist.
Yeah. Yeah.
That's
there's definitely, there's, parts around here that are similar, suburbs that are very similar to that. But one of the, I guess one of the things that I learned recently about a mentor of mine, I took a course, a very intensive course a few years ago out in San Diego. And he's been practicing for 50 plus years. And he definitely has that, I don't really care what you think. Because
we're all trained to get to.
And I love it because it's pretty clear and he makes it clear, he's not shy about saying, I don't have to be here. I don't have to practice. I could retire tomorrow, but he does it because he loves to lecture and he feels that if he's not doing it day in, day out, he shouldn't be talking to people about something he did 10 years ago. But he has, I love that he has a full, like a checklist for his consultation and for his exam. And it is extremely thorough. If I'm going to be totally honest, some of the stuff on there, I'm like, I don't even know how the hell to measure that. What is that?
Yeah, right.
Wow. And then he has another one that is condensed for patients that he's not going to treat. Like he walks in there and he pretty much makes the decision. In some cases, he says, we all see him, within 5 minutes. Nope. And but he says, I document it. I do an exam. It's still very thorough, but I'm not spending all that time because my decision's already been made. And he's not shy about telling them.
I was going to say, what's the parting word? Like, I want to hear from his mouth. He's like done this semi-thorough investigation and he sits up and he's like, yeah, I'm not doing it. And does he just peace out?
I think it's very, I don't know that he gave us the actual,
I want to hear
exact parting words, but he pretty much says, and his TC is phenomenal. Like, just
of course,
absolutely phenomenal. And he said there are days where he just knows. He gives her a look, walks out of the room, and he knows he doesn't have to take care of it. He said one time this lady was she told her, I'm sorry, we've done this. This would be the recommendation, but we really recommend you go somewhere else. This is just probably not going to work in our office, and it's just not going to work out. And she said, well, I mean, why? What is it? What did he say to make you think that? She said, well, it's actually not what he said. It's what you said. And his mind's pretty much made up. It's like, all right.
Okay.
That's, I mean, how do you come back from that one?
But can't.
That's there is also, because I hear this too from friends sometimes that say, somebody threatens with leaving a terrible Google review. And I'm going to tell all my friends about it and what a horrible experience it was. And this is the part that, I think I'm getting to that point now in my career where, I just don't care. And I'm just enough dead inside that it doesn't bug me to think, you know what? I don't want your friends.
Dead enough.
Because if they're friends with you, they probably think like you. And I really don't need the headache. I'm good with you bad-mouthing me. And chances are, especially with the way comments work now, if you have a bunch of great reviews and there's one terrible one and everybody starts to kind of pinball through it and people start to see the crazy because it comes out and they start agreeing with the crazy, that's awesome. It's like, oh, that problem's fixing itself. I don't need you. And if there are people that look at, a certain restaurant or something, a new place in town, and they look at all the different comments and they stick to the one negative one, and that's all they look at, fantastic. And that's how they make their decision. Please don't come see me because you're going to be that pain in the ass patient that no matter what you do, you're never going to please them.
That's so true.
And it just
We
doesn't
love
matter.
a negative Google review about the fact that we made someone take x-rays or we denied them services because they wouldn't take it. I'm like, yes, now someone will see that. Like maybe that will deter someone else who doesn't want to take x-rays from coming in and then making me have to clog up my whole day to explain to them why, in fact, we have to do this, blah, blah, blah. And there's a tremendous amount of psychology. And I don't think we spend enough time on this in our education. There's a tremendous amount of psychology in how you perform as a clinician with people you like and who believe in you and trust in you. And we're actually pretty terrible clinicians when it comes to people who we don't like to be around. We feel they don't trust us. Like you get that sense that like every move you make is being judged and scrutinized and whatever. Your best clinical outcomes are from the patients who sit down in their chair, open up, and they're like, whatever you think, doc, just make it work. I trust in you and I believe that you are taking good care of me. Even when things don't go well, you're still going to give them the best clinical outcome versus the person you're tiptoeing around or like constantly worried about their trust in you and whether or not you're doing the right by them. And I'm not talking about the anxious people. I'm talking about general lack of trust. And there's a tremendous amount of psychology that goes into clinicians performing very, very well when the people they're working on have full confidence in their capability. And that probably is where that doctor is like, you don't trust me. We have trust issues. I'm not doing this case anymore. Like,
yeah, exactly. And that
he looks great when he's working on people who believe in him. I mean,
that's the reality of it. And that's the thing about orthodontics. And I think it's similar with Myo, where a good patient can make you look really good. A bad patient can make you look really bad, even if you did everything. And you may have actually done a better clinical job on the patient that looks bad, but just broke everything you put in their mouth, never wore elastics. Hygiene was horrible, but you're literally sitting there looking at this case and saying, if you just do this for 6 weeks, this thing is going to look miraculous. And you just will not do it. And you're just sitting there, wanting to tear your hair out. And with myofunctional therapy, it's very similar. And the added curve to that is with myofunctional stuff, especially if we catch it early, it's really hard to motivate a kid that's probably maybe already a little ADHD because of all the other stuff and again, total different conversation and different topic. But with some of these kids that aren't sleeping, that maybe they're just kids. We kind of forget sometimes that, hey, so dealing with 8-year-olds sometimes, you can't expect them to have the maturity level of an adult, but you're trying to get them motivated. You're trying to get the parents on board. And this is, especially myofunctional stuff, it's even more difficult than brushing well with brackets on, wearing elastics, even if it's 2 on each side. And I mean, it's a habit. You got to break a mind-muscle connection and form a new one. It takes some work, but the ones that do, I'm going to say the few, but hopefully that number grows. The few that I've seen that really did do it, man, it's pretty remarkable. But it takes a lot of effort and trust from the parents as well. That's another big part, but it's in part as well. When I tell them what may happen, and then it happens, sometimes they get it. Yeah, those are the ones that I think have come back where we finished phase 1. I told them, you gotta go see my functional therapist in this observation phase because that tongue is still going. I'm telling you, it's held down now, but it's not going to stay there. And then they come back for observation a year later, and they're like, "Why is the bite opening up again?" Like, remember? Oh, that's right. And then they go, and now they kind of believe. And then there's the other ones that don't remember, don't believe it, don't buy it.
Right.
You just need to fix it because we paid you, blah, 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 whatever. It's like, okay, well, I told you this is what's going to happen. If you didn't do this one little step, well, that doesn't matter because all my other friends didn't have that.
Yeah.
Okay, well, and then at that point, that's kind of, the answer there would be, I'll tell you what, I will reimburse you your whatever you paid here. You sign a release and you can go to your friend's orthodontist and let them do it. That's it. And I think, Chad, you gave me that idea years ago on a patient that we did just that. Actually, I knew we were never going to make him happy. I said, well, luckily it wasn't too much, because it was just like partial treatment or something like that for some relapse. But even if it is, and it almost becomes the deal where, yeah, if it's a very big reimbursement, hey, it's worth every penny, because now they can't hold that over your
That's
head
right.
either, you know?
Yes, Chad. Are you muted? Chad,
can't hear you, buddy.
You muted yourself on your own podcast?
That is
I
awesome.
done it by accident. Sorry, but hey, so anyhow, we're like way over, but this has been great.
My bad. Sorry, man.
No, it was awesome.
No, this is fantastic. But one of the things that I was going to say, I think this is something really good to close on, is you talked about the bad patient, the good patient. Let's think about it this way. The bad patient is going to end up elsewhere 9 times out of 10. And the good clinician that they go to the next time is going to follow up with exactly what you told them and realize that it wasn't the problem of the clinician. It wasn't the treatment plan. It was the actions of the patient that made the whole situation not work. So anyhow.
Well, and in fairness, Chad, if I could just say one thing on that, sometimes it's just the right match.
Like 100%.
That's true.
It's
100%.
Just the right patient with the right doctor. It doesn't mean the patient's good, bad, or indifferent. It's just not a good fit. And you don't marry every person that you meet. You don't become best friends with every person you meet. We're not all compatible personalities or styles. So it's just finding the right person you trust. And then usually everybody can be very benefited in that type of relationship.
That's it. And it's not necessarily disagreeing with the previous treatment plan. You're right. It's a level of trust too. And but we're still in most instances, the good clinician is going to agree with the previous treatment plan. It just may be that that's a better fit for that patient. So
that's right.
Yeah.
With that being said, I think that we all need to understand the value of appropriate referrals. We all need to understand the value of myofunctional therapy. We need to understand the value of dentofacial orthopedics. So whatever the hell that
whatever
is.
that means.
Whoever knows what that means.
But man, it was kind of like I was sitting here just beaming the whole time, because it's not very often that we get to work with people that we work with on a daily basis. I've taught Jose a lot of what he knows about orthodontics, and I've taught him a lot of what he knows about golf. So,
Yes. Yeah, those 4 3-putts I had last week, but that was great. I was using your mentorship.
All kidding aside, it was fantastic. And I think that we need to find a good myofunctional therapist to get on the show. And I think we met some at Chicago midwinter.
Yeah.
Jose, thanks so much for being here tonight.
Thank you guys, man.
My pleasure. A spirited conversation, such a great conversation. I think we learned a lot. And I think indirectly we got to all of the topics that we discussed prior to the show in one way or another. So we got to learn a lot about your philosophy. But one thing that I did want to hit on is that, for extractions, it's not all or none.
Mm-hmm.
It's
absolutely.
It's when they're needed, they're needed. And Jose and I've had numerous conversations where he's like, dude, we're going to have to extract, and this is why. And so the moral of that story is get to know your referrals, interview them, ask them questions, have an open line of communication. And with that, that's our show. So
good, bad, or indifferent. If you don't like it, we're just not the podcast for you. It's okay.
That's it.
Yeah, that's
all right. Okay.
Hey, I did want to say one more thing completely unrelated to our show tonight, but I think it's important. I just want to give credit to our good friends at the ADA and the AGD, Dr. Merlin Omer with the AGD and Dr. Brett Kessler with the ADA. And I just want to say that regardless of comments that are made, we're never in any way, shape, or form bashing or disparaging our friends in organized dentistry. We have utmost respect for you all, and we thank you for what you do and the fight that you put forward for our profession. So thank you both very much. And not just you, because it's not just you two. I know you want to say it is, but it's not. It's the teams that you all have around you. So
That's
thank you
right.
to the ADA and the AGD for everything you do for dentistry and for Dentists in the Know. And with that, good night, everybody.
Good night.
Good night.